Welcome to this explainer. Okay, today we are diving headfirst into a really high-stakes medical mystery, one that bridges the gap between raw human anatomy and split-second survival. We're going to decode one of the most fundamental, literally life-saving techniques in trauma surgery, the Pringle maneuver. And, this isn't just about learning how to use a surgical clamp. It's really about understanding the incredibly intricate anatomical highways of the human liver. Picture this. It's 2 a.m. in the trauma bay. A 24-year-old guy rolls in after a high-speed collision. He's suffered massive blunt abdominal trauma. His blood pressure is sitting at a dangerously low 70/40, and his abdomen is completely rigid. So you rush him straight to the operating room. But the second you open the abdominal cavity, you are met with a surgeon's absolute worst nightmare. Both dark venous and bright red arterial blood are just rapidly flooding the operative field from this massive grade 4 liver laceration. Blood is pooling faster than 2 high-capacity suctions can even clear it out. But you know exactly what to do, right? You rapidly execute the Pringle maneuver. You navigate your finger behind the lesser omentum, you place a vascular clamp right across the hepatoduodenal ligament, and you click it shut. And just like magic, the bright red arterial jetting instantly stops. You let out this huge sigh of relief, but honestly, it only lasts for a microsecond. Because you look back down at the operative field, and brisk, dark venous blood is still relentlessly welling up from behind the liver. So, that brings us to the central dilemma of this explainer. Why on earth did clamping the entire inflow to the liver completely fail to halt the hemorrhage? What anatomical anomaly or what hidden major vascular structure is still pouring blood into your field? Well, to figure this out, we can't just look at our surgical tools. We have to zoom in and look closely at the microanatomy itself. And that leads us perfectly into Section 1, Anatomy of the Hepatoduodenal Ligament. Let's break down the exact structure we just clamped. The ultimate target of the Pringle maneuver is the hepatoduodenal ligament. Now, keep in mind, this isn't a typical ligament like you'd find in your knee or your elbow. It's actually the free right border of the lesser omentum. Crucially, it forms the anterior boundary of a space called the epiploic foramen of Winslow. And the whole reason this very specific piece of tissue is our target is because it acts as the primary conduit, basically a biological cable that houses the liver's lifeblood. What's super fascinating is what's actually packed inside that biological cable. It houses the portal triad. This triad is made up of 3 absolutely vital structures: the common bile duct, the proper hepatic artery, and the portal vein. So when a surgeon places a Pringle clamp, they are actually compressing all 3 of these structures simultaneously to completely shut off the inflow of blood to the liver. And guys, we aren't talking about a tiny trickle of blood here. Through this delicate little ligament flows roughly 1,500 milliliters of blood every single minute. That accounts for a staggering 25% of your total cardiac output. Just think about that for a second. 1 solid quarter of every heartbeat goes right through this exact anatomical choke point, which actually brilliantly illustrates our opening dilemma if we use a pretty simple plumbing analogy. Think of the human liver like a massive, high-flow industrial radiator. It gets its water through a single main supply line. That's the portal triad we just clamped. Then it drains out through these back wall exhaust pipes into the city main, which represents the retrohepatic inferior vena cava and the hepatic veins. Executing the Pringle maneuver is exactly like shutting off the main water supply valve to your house. So if water is still flooding your floor after you've turned off that main supply, well, the leak isn't coming from your sink faucet. It means the huge municipal sewer line behind the wall has burst. And that right there is exactly why that dark venous blood was still welling up at 2 a.m. Now that we've got a solid grip on the anatomy and the plumbing of it all, let's head to Section 2, Executing the Pringle maneuver. Let's go right back into the OR and see how this is physically done. This maneuver goes down in 4 rapid-fire steps. First, you expose and identify that free border we talked about. Second, and honestly this is the most critical part, finger navigation. The surgeon passes their left index finger from right to left right through the foramen of Winslow. This ensures absolutely no other tissue gets trapped between the hepatoduodenal ligament and the vena cava. Third, you place your occlusion device, like a Romal tourniquet or a vascular clamp. And finally, you clamp it shut and, immediately, you start the clock. But, this doesn't happen in a vacuum. There are some vital clinical bedside pearls that totally dictate whether this succeeds or fails. First, you absolutely must warn anesthesia before clamping. Shutting off 25% of cardiac output drastically spikes systemic vascular resistance, and venous return to the heart suddenly plummets. Second, keeping a low central venous pressure, ideally under 5 millimeters of mercury, is basically your best friend because it prevents that gnarly back bleeding from the hepatic veins we saw earlier. And lastly, beware the avascular plane trap. If you use crushing forceps here, you can permanently destroy the delicate portal vein or bile duct, which is obviously a disaster.
All right, so once that clamp clicks shut safely, the bleeding stops, but a totally new, invisible threat begins. Which brings us to Section 3, beating the ischemia clock.
The moment you cut off oxygen to the liver, a devastating biological domino effect kicks off at the cellular level. First, mitochondrial oxidative phosphorylation just completely halts, which leads to immediate ATP depletion. Without that energy, the sodium-potassium pumps on the cell membranes just fail outright. This causes massive cellular swelling, which ultimately triggers an intracellular calcium overload. If you leave it clamped too long, the cells die. And when you finally unclamp it, the sudden rush of oxygen causes a massive, dangerous inflammatory reperfusion injury. So, as you can imagine, timing is literally everything here. And your time limit highly depends on the baseline health of the patient's liver. A normal, non-cirrhotic liver, it can actually tolerate continuous clamping for up to 60 to 90 minutes. But a damaged, cirrhotic, or heavily fatty liver, you have a maximum of 15 to 20 minutes before irreversible failure sets in. To manage this during really long procedures, surgeons use an intermittent schedule, usually 15 minutes on, 5 minutes off, just to let the liver breathe and recover. But hey, what if you did everything perfectly? The anatomy was spot on, the finger navigation was flawless, the clamp is totally secure, but arterial blood is still spraying everywhere. Welcome to Section 4, surgical traps and the missing puzzle piece. We all know human anatomy loves to throw curveballs. In fact, in about 11 to 15% of patients, you'll find what's called a Michel's type 3 anomaly. This is a replaced or accessory right hepatic artery that actually originates off the superior mesenteric artery. And why does this matter so much? Because it physically travels posterior to the portal vein, meaning it can literally sneak right behind a high-placed Pringle clamp, totally escaping your attempt to shut off the arterial inflow. Oh, and it definitely gets trickier. There's also a Michel's type 2 anomaly, which is an aberrant left hepatic artery. This vessel takes an entirely different route altogether, traveling way up in the fissure for the ligamentum venosum. It completely bypasses the hepatoduodenal ligament. So if you clamp the Pringle, but bright red arterial bleeding is still coming from the left lobe, clamping the Pringle alone is never going to stop it. You have to recognize that anatomical variant on the fly and clamp the lesser omentum itself. So let's bring it all together and finally solve our 2 a.m. dilemma. You see, the Pringle maneuver isn't just a treatment, it is a master diagnostic tool. If you clamp that hepatoduodenal ligament and arterial bleeding persists, well, now you know to use your anatomical knowledge to hunt for an aberrant artery bypassing your clamp. But in our specific case, the arterial bleeding stopped and the dark venous blood persisted, so our diagnosis is crystal clear. The main supply line is off, but we have a major sewer line leak. We are dealing with a catastrophic injury to the retrohepatic inferior vena cava or the hepatic veins, and we have to immediately pivot to damage control packing. Because at the end of the day, anatomy isn't just flat pictures in a textbook, right? It is a highly dynamic 3D puzzle that literally dictates human survival in moments of absolute chaos. The hepatoduodenal ligament might be small, but mastering it really holds the key to life and death. So I want to leave you with this final thought. When the main supply valve is tightly shut, but the room is still rapidly flooding with blood, are you prepared to find the hidden leak? Thanks so much for joining me on this explainer, and keep learning.